Hello there, this is John, and this is chapter 26, Behavioral Emergencies. So, the definition of a behavioral emergency is when someone has a psychiatric condition that's not being treated for one reason or another, and their behavior becomes intolerant to um, their family, their friends, and even themselves. So, this crisis kind of comes to a head to the point where either the patient or someone else calls 911. As you're driving to this call, you might get some information from dispatch about this patient. They might state that according to the records, this person has a psychiatric condition. So, my only recommendation is don't get blinders on. When you arrive on scene, make sure that you really do assess this person for other causes. There's a number of medical reasons why people can act bizarre and act like they're having some type of psychiatric condition. So rule out, hypo and hyperglycemia, stroke, seizure, fever, infections. Those can all cause bizarre behavior in people. The difference is medical causes like those, they come on fairly quickly, maybe a day or two, maybe even hours sometimes. Whereas if this is a true behavioral emergency caused by a psychiatric condition, that usually takes weeks for it to fully manifest to the point where we get called. It's really important that we understand that if this patient is a psychiatric patient having some type of emergency, physiologically, they're really not at risk of dying at this moment. So we have plenty of time on scene. This is the call that you're going to be spending some time at scene with this patient to ensure that you understand fully what's going on. They feel comfortable being transported, and you can understand like the best place to take them to as well. So you need to build some way of communicating with these people. You need to gain their trust. Literally, you can approach them and maybe stand back a couple extra feet away from their personal space and say, "Hi, I'm John. I'm here to help you. I'm an EMT. Your family called because they're concerned about you. I'm not a police officer. I'm here to help you. Can we talk?" So you're building this rapport with them. You're building their trust. A lot of times these people going through these psychiatric emergencies, they can have paranoia. So you want to try to break through that, hopefully, and gain their trust. When you are asking them questions, once they're able to communicate with you, you're asking sample questions. Probably the three most important questions to ask these patients is one, do you feel like you want to hurt yourself? Number two is, do you feel like you want to hurt somebody else? Or are you taking your medications on a regular basis? More than likely, the reason why they're having this psychiatric emergency right now is because either they stopped taking their medications or the medications that they are on just aren't working for them any longer. So once we've made a determination that this person is possibly having some kind of psychiatric condition, then we have to decide what the outcome is going to be in all this. So patient consent, what type of consent applies to my patient? So many patients that are having psychiatric emergencies, they're fully oriented. They know person, place, and time. But that's not really enough for us. So we have to get an understanding of what's their capacity to understand what's going on today and the risks of possibly not going to the hospital with us or not going to the hospital in general. So if they cannot prove capacity, then we really can't use informed consent. We have to use then involuntary consent, especially if they say, I want to harm myself, I want to hurt others. That's a slam dunk. They need to go to the hospital, even in restraints. Even if the patient doesn't say this, but the family tells you that the patient's been talking about hurting themselves, that's enough to take them to the hospital. It's better to just restrain them, take them to the hospital, have them evaluated. It's safer for you legally, and it's safer for the patient physically. So when it comes to law enforcement, there's two general scenarios you're going to encounter out in the field. First is you're going to get called out to a patient, you and your partner, and maybe a fire truck possibly. And the patient, you go through your assessment and you determine that this person is having a psychiatric condition. They are having kind of a meltdown and they do need to go to get help. So maybe for one reason or another, you can't really decide exactly what's the best course for this person. So you could have a police officers arrive on scene. You can discuss this with them. They can give you a hand with that, making decisions about the patient's right of refusal and consent and all that. Um, if if you are planning to apply restraints, you don't have to have police officers there legally. In the county of San Diego, as long as the patient, you determine that the patient is a risk to themselves or others, you have a right to apply restraints to anyone. But what's nice about the police officers, you can actually call in the PERT team, and this is a nurse that's trained. It's a psychiatric emergency response team nurse that rides along with the police officers, and that nurse can come out and do an evaluation on the patient, determine the best, what's best to do with this patient, what's the best hospital for this person, and even to the point where possibly the nurse might put the patient in the back of the squad car and drive themselves to the private psych facility, because that's really the best place to get their treatment. There's really no reason for them to go to an emergency room. They need to go to a psych facility to get whatever they need. Also, maybe you get called out to a welfare check. Maybe someone calls 911 and says, "Hey, I haven't heard from my cousin Bill for quite a while now. I've been calling him and he's not answering his phone. I'm really concerned." It's great to have police officers there to knock on the door, because for legal reasons and safety reasons for you, and if you do need them, because they might need to restrain the patient or they might need to put the patient on hold, then that's great. Now, the other side of this is the police come out first and they're on scene with a person, and they're trying to determine what to do with them, and they decide they need to be transported. So they call dispatch and they ask for an ambulance to show up. So you show up and there's a patient there. They're going to be handcuffed, and you're going to find the officer in charge and you're going to say, what's going on and what's my patient's status? And they're going to say, well, the patient's in custody, they're under arrest, and they're on a 5150 hold. So if the patient's under arrest, the patient no longer has a right to refuse care, transport, or treatment. If the police officer themselves makes that decision in conjunction with, consultation with you, you guys get together and decide what's the best for this person. Is the officer going to transport the person, or are you going to transport in the ambulance? On the other hand, if this patient is only detained, they're not in custody, they might still be handcuffed just for the safety of the officers, pending some type of background check or something like that. The patient still has a right to refuse care, assessment, treatment, and all that. So once a person is placed on a 5150 hold, they are taken either to the emergency room for a physical evaluation prior to being transported to some type of psych facility, or if there's no physical injuries, there's no overdose issues, they can go directly from the scene to a psych facility for a 72-hour evaluation. At the end of that 72 hours, they get brought before a judge, and the doctor says that this person's okay, he can be released, or the doctor says no, he's still having issues, that we want to retain him for another week or whatever it is, and the judge approves this. So the person's still on a hold and he's still in custody at this psych facility. Now, let's say you are working as an EMT on an ambulance and you get called to that psych facility to transport this person on a hold to go to an emergency room because he has another unrelated condition. Maybe he has a fever or something like that. So to keep him restrained and keep him on a hold, you have to bring the original documents with you that are signed by either law enforcement, by some kind of physician, or some kind of psych nurse. Because if you don't have that document with you, then once you get to the hospital can't hold this person. They would legally have to release him. And so it gets really complicated. So make sure before you leave the facility where you're transporting from, Make sure you have that whole documentation with you, with the patient. So if you're as you're going through your assessment, you're communicating with your patient, even uncooperative patients, people that are reluctant to talk to you, who are slightly argumentative, I guess is a better way to put it. As you can build a rapport with them, you can talk to them, you can get some kind of information out of them. If at some point this person says they want to harm themselves or they want to harm others, well, that's kind of a slam dunk. They're automatically going to be taken to the hospital against their will by implied consent, and even to the point of, obviously restraining them. And again, if someone says, they want to hurt themselves, that's one thing. But again, even if the family says it, or the neighbor says they overheard it, or someone else close to the person says they heard the person making these statements, that's enough to feel this person needs to go to the hospital and be evaluated. Now, when it comes to high at-risk populations for self-harm, the biggest one we see here in the county of San Diego are people that have been diagnosed with a terminal illness, and perhaps they've been told by their physicians that the last few months of their life is going to be horrible, miserable, and in agony. That person might, want to do something to harm themselves because they don't want to go through that last few months of their life. So protecting yourself. So situational awareness is really important. And this isn't just on scene. Anytime you're on duty, you're driving around in a big red ambulance and a big red fire truck, you have a uniform on. We are constantly watched by people. We are targets for people. So you always want to make sure of your safety, even when you're not running a call. But when you're on a call, it's even more necessary to heighten your awareness of what's going on. Sometimes it might not even be the patient that's the aggressor. It might be a family member. It might be a friend or a coworker that feels that you're being abusive or disrespectful to the patient, and they start becoming aggressive with you and your crew. So it's important that we keep an eye on everyone on scene. Now, the difference between a combative patient versus an aggressive patient. So an aggressive patient is someone who's usually doing it on purpose, meaning that they want to either get away, and one way of doing that is knocking you to the ground, or they have some type of homicidal, desire to hurt you. This person's coming at you aggressively with or without a weapon. On the other hand, a combative patient is someone who might be under the influence of drugs or alcohol. They might have had a stroke. They're disoriented. They're confused. And because of the confusion and because of their combativeness, you need to restrain them. And so when it comes to these two different patients, there are two different ways of approaching this. So if you have an aggressive patient who's coming at you with or without a weapon, if you can get away, run. That's the best thing to do, is just run away. If you can't, you can do something to incapacitate them. You can hit them in the throat. You can kick him in the groin, whatever it takes. The guy's on the ground rolling around, holding his groin. Run away. You've taken care of the problem. You're gone. And then call the police, and they can deal with it after that. The trick to all this is using no more force than necessary. Now, obviously, if you have an aggressive person, if you incapacitate them, they're on the ground rolling around, they're on the ground unconscious, that's fine. Run away. Great. If you have someone who's combative due to a medical problem or a traumatic injury or drugs or whatever it might be, use only the reasonable amount of force you need to protect yourself and the patient. For instance, let's say you go to a convalescent home. You have a 102-pound Alzheimer's patient. She's a little old lady, and she's super violent. Unfortunately, these Alzheimer's patients can actually go into these stages of severe violence and aggression. And so she's flailing around. She's trying to scratch us. She's trying to spit at us and all that. So this is your combative patient. She doesn't really know what she's doing. She's not doing it on purpose. And so, four people, maybe five people, could easily restrain this little old lady to a backboard with soft restraints with minimal harm to her, and that's reasonable force. On the other hand, you get called downtown for a 300-pound weightlifter on PCP, and he's going berserk. And it might take 10, 12, 14 people to hold this person down safely to where you're safe and the patient's safe as well. So if you did go to court because the patient later on says, you broke my arm or you caused me permanent disability because you were so forceful when you restrained me, you can say, well, in fact, we use this many people because of the size of the person. Ultimately, do not become the aggressor. If you have a person who's coming at you, they're an aggressive patient, and you feel your life's in danger, you have a right to protect yourself to a point. Once this person is no longer a threat, run away. Like I said, if you kick him and in the groin and he goes to the ground and he's moaning and you keep kicking him after he's on the ground, that's a felony. And you're going to go to court. They're going to sue you, and you might even do some jail time for this. So, run away, best thing to do, and make sure that this documentation is done really, really carefully on these calls, because it's a good chance you will go to court on these calls. Okay, speaking of reasonable force, there is a situation that we encounter out in the field. Luckily, it's fairly infrequent, and it's called excited delirium. This is the person who is probably under the influence of some type of amphetamine products, and they become so hyperthermic. And I've encountered these patients, they have core temperatures of 104, 105, 106, which is just crazy hot for somebody. They are hyperactive. They're dumping tons of dopamine, adrenaline. They're building lactic acid. And basically, they're so disoriented and so out of it. They have no idea what they're doing. And they're so aggressive. All they want to do is break things, hurt things, and kill things. They're incredibly violent. They're incredibly bizarre behavior. You can't talk to them. You can't play nice with them. They're extremely dangerous for us. This is a patient that it might take 10 or 12 people to hold them down. They're super, super strong. Even a small person who doesn't seem very muscular in this situation can be extremely violent and extremely strong. The other part of this as well is because they're dumping so much lactic acid and because they're so hyperthermic, they can die suddenly during this process. And there's been documented cases, and I've seen it myself in the field, where 1 minute you're on the ground with this person trying to restrain them, and they're struggling under 5 or 6 or 7 rescuers trying to hold this person down to restrain them to the spine board. And then suddenly the patient goes limp. And when they went limp, their heart had stopped. So they do die, these sudden cardiac arrests, because of all of this, the lactic acid and all this adrenaline release and all that. If they are still alive, of course, restraints are the highest priority because your safety as well as the patient's safety. ABCs, do the best you can. Don't get your hands near their mouth for obvious reasons. Rapid cooling measures, cold packs, those types of things. And, if you're a long way away from an emergency room, you might consider ALS. We do have things to sedate these people. The only problem is that, once I inject them with something, it could take up to 10 minutes for that injectable to cause them to slightly calm down. So in the meantime, you're going to be busy for obvious reasons. So looking at this picture right here, you think to yourself, okay, this person's going through this restraint process. The guy in the colored t-shirt there, the rescuers are holding on to his limbs and all that. But really, what's wrong with this situation? What's really missing from this particular situation? And it doesn't really take a lot. It doesn't take a lot of, knowledge when it comes to medical things. It's just common sense. So if the guy has 4 limbs, there's 4 rescuers, each one's holding a limb. There's no one there to restrain this person. So if these people take their hands off their arms and limbs to restrain them, you can see it's going to turn into a clown show. So you need at least 2 more people, a total of 6 or more people, to restrain this person safely for you and safely for them as well. So you're going to have 4 people securely hold their limbs in place. You're going to lay this person back onto a spine board or onto a gurney, and then one person is going to apply and tie the restraints to the upper limbs, and one's going to do it to the lower limbs. Secure this person to your backboard or wherever you're securing them to, and that's a safe way of doing it. Now, obviously, you need to document all this kind of stuff. So if you go into your protocol book, and it's in the back of the book in the white pages, go to S422. It gives you a whole idea about what you need to document, what kind of restraints you can use, who you can restrain, and who can restrain patients, and those kinds of things that you need to document. So the restraints themselves, the most common restraint that we use in EMS are called posy restraints, and that's the blue restraints you see in the picture. These are non-reusable. They're soft restraints with foam padding, and again, one-time use. Once you apply them, you don't really have to untie them. You don't have to recover them. Once you get to the hospital then can cut them out of the restraints, and then they can apply their own restraints at the hospital. There's another version that I don't have here, and these are Velcro restraints. And it kind of looks like a double surf leash. So one of the sides attaches to the gurney or the spine board, and the other side attaches to the limb, just like you would do a double Velcro surf leash kind of situation. The leather restraints you see down in that lower right picture, those are only really found on non-emergency ambulances. And the reason why this is if these do get contaminated with blood or vomitus or other secretions, they have to be thrown away, and they're rather expensive. So if you work on a 911 apparatus, you're going to get either the Velcro or the posy restraints. The gentleman up top there with the funny looking thing on his head, that's a spit sock, and obvious reasons, this guy's been spitting, goes over the head, kind of protects us. When it comes to who can apply restraints, anyone on duty, firefighter, EMT, paramedic, as long as you have a reason to do so and you do it correctly and safely. When it comes to positioning, the county says that the patient needs to be on their back, supine on the spine board or supine on the gurney. They do say that in the process of restraining the patient, if you need to put them in a prone position temporarily to get them under control, but once you have control of the patient, they should be flipped onto their back and placed in that supine position. What to monitor? Well, of course, obviously, you've applied restraints to a limb, so you want to make sure that all 4 limbs, that the pulse, motor, and sensation are still intact. And you want to obviously monitor their airway, breathing, and circulation at least every 15 minutes or so. And we want to document that. You want to document what types of restraints you applied, what limbs they were applied to, why they were applied, and what agency did the application. Now, if you're working with police officers and the patient's in custody and the officers have handcuffs on them or plastic ties, then the officer has to come with you to the hospital, either in the back of the ambulance with you or follow directly behind in their squad car. And that's county protocol. Lastly, with this, obviously this picture, the gentleman with the green bag and the radio probably really shouldn't be where he is. He should be running away right now, calling for law enforcement to come and subdue this person before they can restrain him. Again, documentation is really important, especially when you are in the back of an ambulance. And there have been situations here in the county, I've experienced them myself personally, where as a male paramedic or a male EMT, I'm transporting a female patient, and this patient's either having a psychiatric condition or they're under the influence of drugs or alcohol, or for one reason or another, they just don't want to go to the hospital. And they're angry, and unfortunately, they threaten to tell the police officers or to tell the doctors that you did something inappropriate to them while en route to the hospital. And it's not that common, but it does happen. It's happened twice to me in my career. So it's really important. I learned early in my career, bring a witness with you, whether it's a police officer or whether it's a firefighter, a lifeguard, somebody in the back there who can, witness the fact that this actually did not happen. Now, ultimately, maybe you're going to the hospital with someone in restraints, and now they say, hey, I feel a lot better. I don't feel angry anymore. I feel really nice. I think we could be friends. Could you please, untie me? Don't untie them. Just be nice and say, I do apologize, but based on my protocols, I'm not allowed to remove your restraints until we get to the hospital, and the doctor will have to make that determination. I think we're done.